Dear colleagues, on behalf of all my co-authors, it is my great pleasure to present our data on the molecular and pathological patterns of treatment failure in MTC patients treated by RET selective inhibitors. Here are my disclosures. MTC is a rare cancer and accounts for less than 5% of all thyroid cancer. It is characterized by a high frequency of molecular alterations in the RET oncogene, which can be found in up to 80% of the case. Recently, RET-specific inhibitors such as selpercatinib and pralsetinib have shown great efficacy in this patient population. Unfortunately, progression occurs and resistance mutations have been reported, mostly in patients with lung cancer, but also few reports in MTC. Here, we report the pattern of treatment failure in our MTC patients who discontinued RET selective inhibitor, RET-I, between March 2018 and March 2022. This was a monocentric retrospective study performed at Gustave Roussy among 47 MTC patients who were treated with RET-I. 19 discontinued treatment during the study period. Available clinical, molecular, and pathological data were collected, and when available, pre- and post-RET-I tumoral samples were reviewed by Abir Al-Ghuzlan, our expert pathologist. Among the 19 MTC patients who discontinued on the study period, the main reason was progressive disease in 63% and MTC-related death in 21%. One patient was lost to follow-up and was excluded. 18 evaluable patients, they were 63-year-old, 39% were female, and the most common RET mutations were M918 and C634 in 61 and 22% of the cases, respectively. 83% of the patients were pretreated, at least with vandetanib, and 8 patients received selpercatinib, 7 patients received pralsetinib, and 3 patients received the both treatment. In 10 out of the 18 patients who discontinued RET-I, a post-treatment molecular profile was available, mostly from liquid biopsy for 80% of the cases. In all the patients who discontinued for disease progression, we found one or several resistance mutations, as shown in the table, mostly bypass mutation of resistance on KRAS and HRAS. We also found RET G110 and 806 resistance mutations, as previously described by others. In patient 9, multiple subclonal on-target mutations occurs, especially the Y806 mutation. Interestingly, in patient 8 and 15, who discontinued RET-I not because of progressive disease, but because of observance issue and toxicity, no resistance mutation was found. For 6 patients, we had tumor samples from initial diagnosis, pre and post RET-I. As you can see on the left panel, but also on the graph, we observed an increase in the mean Ki-67 over time, especially following progression under RET-I. In some patients, and as shown in the left panel, we observed a more aggressive pathological pattern with aspect reminiscent of poorly differentiated neuroendocrine carcinomas. To conclude, resistance mutation was found in all our patients who discontinued RET-I for disease progression, and this can be captured by liquid biopsy. Bypass mutations of resistance seems to occur at a higher frequency, 80%, as compared to on-target resistance mutation. Therefore, other therapeutic resources besides second-generation RET inhibitor will be required for these patients. And we also observe Ki-67 index increase and poorly differentiated morphology after progression under RET-I, which suggests a more aggressive behavior and warrants further exploration. And I thank you for your attention.